Good morning again to everyone. My name is Pam Myers. I'm the program director for the Central Ohio chapter, and I just want to welcome everyone here today to our caregiver Q&A. We're so glad to have you, and I just have a few little housekeeping items just to go over with everyone as we get started. We are muting you audio and video just so that we can decrease on the background noise and disruption as our distinguished guests are speaking. But we want you to know that in Blue Jeans there is a chat feature, and it's up in the upper right hand corner of your screen. You'll see a little chat box, and you're welcome at any time during the next hour to chat in your question. I've also placed some other information there. If you need some follow-up after today's session, if you feel like that maybe you have some additional questions or your question, we didn't get to your question, you can feel free to email me. My email is there in the chat. And I've also placed Dr. Aziz's office number there for reference if any of you need it. So you have that information. So we did have quite a few questions submitted when we sent out the publicity for the Q&A. We did put a link there, and folks could submit questions ahead of time. So we do have several of those questions to go over today. But we also, you're welcome to chat in questions as well. So again, welcome everyone. We're so glad to have you. I'm going to introduce to you our very distinguished guests today. We're so glad that they are here and spending the time with us today. And I see that Dr. Aziz has joined us. So I want to introduce Dr. Aziz. Dr. Aziz, if you want to click your video on, there you are. Welcome. So glad to have you. Dr. Aziz is a leading OhioHealth behavioral neurologist. He's got over 19 years of experience in internal medicine and neurology, and his particular areas of interest and research include neurodegenerative and cognitive disorders like Alzheimer's disease. And in his practice, he provides comprehensive assessment, diagnosis, and treatment for patients with all types of dementia. We also have with us today Ms. Amy Weeks. Amy is a licensed independent social worker and clinical supervisor, and she works as a social worker in the Cognitive Neurology Clinic. She does biopsychosocial assessments, provides supporting counseling, and dementia education to patients and families. And she also, which is very important, assists those patients with resources in the community.
Is there a way to turn the volume up?
Amy has been in the field of aging for 29 years and working in the hospital, community, and many facilities. So welcome, Dr. Amy, or Dr. Aziz. Dr. Amy, that's your first, right?
I'll take it.
Thank you.
Thank you.
So, being here today with us. Thank you, thank you, thank you. And we have a lot of questions that we want to get right to. So if you guys are ready, we'll just get started. Does that sound good?
Yeah, that's great. Thank you everyone to be here. So it's our pleasure to be here to answer the questions and engage in this conversation, especially in this unique time that we are all of us going through. We know that there are many challenges facing all of us, and we are very hopeful this session will help to clarify some of the questions and help everyone understand what's going on better.
Absolutely, absolutely. Thank you so much, Dr. Aziz. So we're going to just step right into the first question, and that is, are there instances that you would prescribe a non-pharmacological intervention to help improve behaviors of individuals with dementia? And if so, what type of intervention may be introduced?
That's a very good question. So before I answer the question, there are a few notes we need to make to explain the answer. So dementia, what does the word dementia mean? Many people confuse the concept of the disease and the dementia. So we have Alzheimer disease, we have Lewy body disease, we have frontotemporal dementia, and so on. So there are different conditions that can affect the brain in a way that it can impair the ability of the brain to function, and subsequently it's affect our independence. So that's the actual operational definition of dementia. So when we are losing our ability to think independently, and that's subsequently affect our ability to take care of our own selves, either with the activity of daily living or the instrumental activities like driving, cooking, and so on. It's with the progression of the dementia, there are multiple behavioral changes that can happen, either because of the dementia itself, or there are comorbid conditions, or our adaptation and adjustment to the new changes in our life. And that fact is very important because the treatment of the behavioral manifestation of dementia depends on the reason of those behaviors. So they are not, those behaviors are not all the same. We cannot treat them as all under the same umbrella. They can be originating from problems in our adjustment skills. So all the time we can get, even if we are healthy, sometimes we have unhealthy adjustment and adaptation behavior. So when your kids talk to you, sometimes you yell at them, sometimes you feel very upset, and to be contained and being able to control your behavior is depend on many factors, including did you sleep well, did you eat well, are you coming from work tired and fatigued. So even when you are contained, you are normal, your behavior can be very variable, and you can show manifestation of an anxiety, agitation, and so on. So understanding the underlying problems that led to the behavior in the first place is very important to suggest any type of intervention, pharmacological or non-pharmacological. And as I said, the reasons for those type of behaviors can be due to the environment. So if I didn't eat well, if I'm not sleeping well, if I'm very bored, if there is too much stress going around me, there is too much stimulation, there are too much TV, I'm not very active. All of those can create create some form of stress, and they can create depression, and they eventually can create some sort of behavioral changes. So that's the first possibility. The second possibility, the disease itself. So we have spectrum of conditions that can cause dementia. Some of them from the beginning, they start with behavioral problem. So like frontotemporal dementia, there is subtype of it called behavioral variant. So it's from the beginning, that's the actual disease. It takes away our ability to regulate our behavior. So we start having either less engagement, we become more depressed, apathy type behavior, or we lose our ability to judge our behavior, is it appropriate or not? And that's when we have problem with manners and we have problems with the way we conduct ourselves. So it could be part of the disease. Lewy body dementia can be associated with hallucinations. So people can see things that's not there, hear voices not there, and that can create fear and anger and so on. So that part of the disease itself. So the first one, it could be reaction to the environment, it could be part of the disease. Medications that we use. So we use medications for different reasons in this population. Most of the people who have dementia are in the older age group, and they are using multiple medications, and those medications can be interacting with each other, creating behavioral problem, making them depressed, agitated, and so on. So that's another reason. And the most important, or the last important one, having some changes, physiological changes like UTI, having metabolic abnormalities. So there are different reasons for the behavior. And when we try to make any suggestion, it should be based on our interpretation of the behavior. Is it coming from something physiological that we need to fix and need treatment? If you have UTI, behavioral adjustments won't fix it. You need to take antibiotics. If you have some chemical imbalance that led to your dopamine is not enough and it's causing this behavior, adjustment won't be enough. We need to treat it. So some of those, if we understand the behavior, we might need some pharmacological interventions. In other types of behavior, there's behavioral adjustment and interventions that can make all the difference. Now let's talk a little bit about those behavioral adjustments that can help us deal with the situation. The most important note about those behavioral adjustments is what is the behavior? So is it the behavior agitation, yelling, pushing, etc. So the behavior itself needs to be well characterized. Two, it's how frequent the behavior. So the behavior, is it something that happened very intermittent versus something happening every day? Is there any variation throughout the day? Is the behavior happen more in the morning, happen more at night when they are tired and fatigued? So the association of the behavior and the impact of the behavior. So is the behavior causing disruption to the daily routine, put the patient at risk? So that assessment of the behavior is very important, because some behaviors can be actually, we can live with some of the behaviors. Others need to be treated because they are compromising the quality of the life of the patient or the caregiver, and they can endanger the patient. So that's the second level. After we ask the question, what's causing the behavior, we need to assess the behavior itself. So after we assess the behavior, if we find that the environment that create the behavior, the reactivity that we are dealing with the behavior are contributing to the behavior, then the adjustment will be accordingly. I will shift the conversation to Amy, so I will give her a chance to speak about some of the behavioral interventions, and probably I will get back to the point too, but I will give Amy a chance to add to this conversation.
Thank you, Dr. Aziz. Yeah, I think it's really important, just as he said, is to know what the behavior is and how long has it been going on. Are there any triggers to the behavior? But I think in general, some things that caregivers can do that don't involve medications, because we don't want to use medications if we don't have to, is making sure that the person has a consistent routine. You know, sometimes changes in routine, even something as simple as having a friend over for lunch or to visit, that can actually cause some behaviors because a patient is out of their routine and they can't explain that they're feeling a little bit anxious, and it might come out in some behavioral manifestations. Trying to keep the environment the same as it always is. So things in the same place. If they have, you know, eyeglasses, making sure that those are put in the same place so that they don't get lost, or keys or wallets. Using distraction can be a really good technique for lots of different types of behaviors. Instead of trying to reason or argue with the person, trying to distract them to something more pleasant can be really effective a lot of the times. I think also trying to avoid overstimulation in the environment. So having a lot of external input, maybe from if there's lots of people around, or there's TV on and the radio's on and they're looking at the laptop, that can just be overstimulating for all of us, much less someone that has dementia. So trying to limit that. Those are just some kind of simple ways that caregivers have control to try to limit the negative effects that come with behaviors. But just like Dr. Aziz said, caregivers, we are humans, and our own emotions come into play too. So we have to look at, is our interpretation of the behavior really something that's negative, or is it our own interpretation of the behavior because we're sad that our loved one is changing, or we're angry that this is happening, or we're very fatigued because we don't have enough help. We haven't gotten a break. Maybe we haven't accepted the diagnosis yet, which should be normal. So I think the caregiver has to connect with their own feelings too, and see where they're at as part of looking at the whole behavioral situation. Because sometimes caregivers, not intentionally, but sometimes their responses can play into how the person's behavior continues.
And It's to add to Amy, which is very good. Amy made very good points there. So the interventions are actually technically two types. There are general interventions and there is specific interventions. So the general interventions that if you make the environment as stable, as routine, as pleasant as you can, so even the temperature in the room, the hydration situation, so all of those environmental interventions can make the beloved one as comfortable as he can be or she can be. And that can make all the difference. If you recognize that they are not sleeping well and you find out they are not sleeping well because they are watching TV a lot, or there is what's happening in the news cycle that around that time, it's making them very anxious, and you make intervention in that type of inputs and stimulation, it can make all the difference for them. Planning ahead of time. So sometimes it's Christmas, it's Thanksgiving. So there are many events that can bring people around the beloved one. It can create behavioral changes. So those are umbrella type general interventions, but sometimes the intervention directed to the specific situation, and that can make all the difference too. And this is when you need some consultation. So sometimes reaching out to Amy, reaching Dr. Aziz, reaching to the behavioral health. There are people, professionals, can help with more directed, specific to that situation intervention. So I have patients who actually have certain type of jealousy delusions and they start acting upon it. So there is specific intervention for that type of behavior. And usually we try to analyze that specific behavior to understand the roots of it, and then we suggest the treatment. So keep that in mind. There are the general interventions. If you do them, you improve the quality of your life and the beloved one life in general, creating a routine and the other things Amy mentioned. But there are more specific interventions related to the specific behavior after we understand the behavior. I hope that answered the question.
Excellent, Dr. Aziz. Thank you so much. We have a couple other questions related to some kind of specific behaviors that folks wanted you to address. One of our constituents wrote in that her husband has Lewy body, which you mentioned earlier, Lewy body dementia, and is starting to complain of trouble swallowing. Is that normal? And what would you advise to do next?
So those type of conditions, they start in different locations in the brain. So we have, the brain controls all of our bodily functions. So we have different level of cognition. Some of it is conscious when we are thinking about visiting our family and so on. And some other functions is reflexive and it's internal. Swallowing, coughing, breathing, all of those are internal functions that maintained in the brain in the subconscious level. Some of those conditions can affect the centers that control the swallowing, either directly through the center itself or through the extensions from the brain, in particular area that's controlled that called brainstem, from the brainstem to the throat where the swallowing and so on, that, or the esophagus where it happens. So is it normal? Swallowing difficulty, by default, it's not normal. So all of us should be able to swallow normal. So it's when this happens, we need to ask a few questions. So the swallowing difficulties, is it for fluids? Is it for solids? Is the patient complain with pain beside the swallowing? Because it could be due to something related to local. So acid reflux disease and some other conditions can create problems to the esophagus and it can impair the swallowing. The swallowing, where it happens, because the food can stuck in the upper throat, in the middle, or in the lower, and that location can help the physician determine the underlying problem. So the swallowing, the answer, is it normal? No, it's not normal. All of us should be able to swallow normal. And when that starts, it might be trigger certain evaluations. The way we analyze it determine the possible reason for it. If it's part of the Lewy body, it can be part of the Lewy body, if that's what you mean by normal. It can be part of the Lewy body, because the Lewy body can affect the vagus nerve, The vagus nerve is the nerve that control the movement of the swallowing. Keep in mind, Lewy body there are conditions can mimic Lewy body. So there is another condition called progressive supranuclear palsy, and that condition more commonly to affect the swallowing. So if that swallowing problem happened earlier, so if your doctor told you that you have dementia a year ago and you start having swallowing problem now, that's a little bit concerning. The diagnosis might be something else. But if it happened, you have the dementia for 7-6 years and the swallowing happened now, it can be part of the natural progression of Lewy body, and it's now affecting the swallowing centers, and we need to be careful. It's when there is some swallowing problem, it's the common thing we do, we send our beloved one to the speech therapist. It can help us to determine the level of the problem. Is it the throat or the swallowing that it's as it happens down in the system itself, the gastrointestinal tract, or is it related to the nerves and the supply that's coming from the brain? So that distinction that happens can help us determine the underlying problem. Then we decide, is it part of the disease or not, and what's the appropriate intervention. Interventions variable, some of them related to alteration or adjustment to the food itself. Sometimes we give some medication that decrease secretions. We do multiple interventions to help with the swallowing problem to prevent aspiration. The main problem with swallowing is having the food going in the wrong passage and end up in the lung, because aspiration pneumonia is one of the most devastating conditions that can happen to our beloved one. The other main problem, difficulty swallowing, can decrease the appetite and patients start avoiding eating. And that's also can be a real problem. So summarizing the answer, is swallowing difficulty can be part of Lewy body? Yes, in the right context. It's worth evaluation. We shouldn't sleep on it because we can do something to make it better. And the best person that can start the evaluation is the speech therapist. So you might start discussing this with your primary or your neurologist to see if they can refer you to speech therapist after they do their initial evaluation. And that can move the ball forward to determine the underlying problem, what's the appropriate interventions, and what dietary adjustment we need to do to prevent the complications.
Great. Thank you, Dr. Aziz. You referenced there, following up with your PCP. We had a couple questions come in reference to if a family is already seeing a PCP, why would they follow up with the neurologist? And if they do follow up with the neurologist, what would happen at that first visit when they come in to see you?
Yeah. That's a good question. And it's a convoluted question too. So your primary physician is the backbone of the health system to take care of you. So we always respect that fact. We always empower the primary physician to take charge of what's going on with our beloved ones, because they are usually more handy than the specialist, and they can answer more efficiently to your questions because they know you, all of you. It's not just one problem, your dementia, and that's it. They usually look at you in the bigger picture. They know that if you have hypertension or not, depression or not, you have dementia or not, and so they have sometimes better understanding than the specialist, who usually dig on one problem, try to answer one question. So the primary physician sometimes take charge and try to help. And many times that's sufficient. It can actually do the job if it's bread and butter type situation. We have beloved one who is 85, starts gradually over the last 5-6 years having some memory problems. And we have family history of Alzheimer, and this is the same way, it's unfolding the same way. So the primary physician most of the time able to handle this, start the medication, help the patients. Other times, if the dementia happened in a younger age, so if you are 65 and you start really having struggle with your memory, or 60 or 50, or so younger age, and start having cognitive problem, it might not be dementia. It might be not be neurodegenerative dementia, which is like Alzheimer or Lewy body. It might be something else. There is other condition can mimic dementia. So the specialist can help to differentiate, is it neurodegenerative or non-neurodegenerative? The specialist, if it's neurodegenerative, some people want to know the specific diagnosis. They want to make sure that it's really Alzheimer, not Lewy body, not frontotemporal, and we have better tools to answer that question. So nowadays, we differentiate those the neurodegenerative dementias. We have many types of them. And even among the common types, there are subtypes. So if you ask me, what's Alzheimer dementia? I will say at least there are 4 subtypes of Alzheimer dementia. The classical one that affect the short-term memory, we call it amnestic or limbic type. There are 3 other types. We call them extralimbic or limbic sparing. They can affect the behavior. We call it behavioral variant. They can affect language. We call it logopenic. And they can affect visual spatial ability. We call it posterior cortical. So even among Alzheimer itself, we have subtypes of Alzheimer. Usually the primary physician doesn't have that type of knowledge. And it can be confusing to the primary and to the family. There's certain manifestation doesn't make much sense. So he's able to remember, but he's not able to find his way. So I have a younger lady was working on a movie theater. She's able to carry herself, but when she goes to her work, she was not able to find the bathroom. She was not able to find things around. So the manifestation was navigation problem, and that was posterior cortical type of Alzheimer. So those type of conditions, this type of manifestations might not be familiar to the primary physician, and he can refer patient to us. So younger age, unusual presentation, rapid course, sometimes the dementia unfolding very fast. And that's concerning because there might be something else going on, and seeing specialists might help you figure that out. As I said, if there is family history, sometimes establishing the family history is important for people to plan ahead. And it's nowadays that knowing the family history become more and more important, because most of the therapy that we are investigating and research is actually supposed to be introduced very early in the disease process, because very early intervention can save brain tissue. Most of the failure that we have faced in the research coming from the fact that we are introducing our treatment, the research treatment, late in the disease. So when the brain tissue is already gone, and now we are trying to stop the disease, and the disease is already advanced. So we are fighting ourselves here, and the benefit is very limited. So to summarize this, so unusual presentations, when there are manifestations that doesn't make much sense, when it's young age, when it's rapid, progressive, when the family want to have a definitive diagnosis, neurologist, my clinic can be very helpful. Otherwise, if it's the bread and butter, many times the primary physicians are sufficient to take care of the situation, and we empower them. In OhioHealth, actually, we have a program trying to create that network where the primary physician can discuss the case with us and ask for our help without the struggle that the patient go through seeing so many physicians, which can be overwhelming. The good news of the current pandemic, we have now the technology, this telemedicine, we have video visit, etc. So that might be a tool in the future to bring the care to your home. And that can be also empowering to the primary, to the family, and make the care easier. So you go to your primary and we come to see you through the video visit at your home. So there is no much stress coming to the physician office, going through new process, etc. So hopefully this answered the question. Anything, Amy, to add to this?
No, I think you covered it very well.
Okay.
I know part of the question was about what someone might experience in a first visit with you, though. That was part of the question.
Yeah, so that's thank you for the reminder here. So the visit, usually we do, it's how we think about the condition. So first we need to establish, is there dementia or not? So this need two-part process, the subjective part and the objective part. The subjective part is the story, when you tell me what's going on. And when I sit with you, try to understand what's going on. That's the subjective. That's your side of the story. Then I take it to the next level with the objective testing. So we do some cognitive assessment and neurological assessment. So we look at the different part of the thinking process. So there is language, there is memory, there is executive function. We try to take you for a ride and test those type of cognitive skills and to determine which part of the thinking process is affected the most, because sometimes it's not affected uniformly. So some people are able to communicate very efficiently, but they forget. Some people are able to remember and communicate efficiently, but they cannot execute. So they cannot do things they used to do. So we try to figure out what's the deficit, and then we ask ourselves, what's the reason for the deficit? Is it something reversible? Because some of the dementias can be due to medical conditions. So if you have thyroid disease and it's not treated and it's ignored, it can cause something similar to dementia. If you have long-standing sleep apnea and you didn't treat the sleep apnea, it can cause something similar to dementia. So we ask ourselves, is it actually neurodegenerative or something else? So we investigate. So we listen to the story, we do some testing related to your thinking, then we ask for some testing, and usually we see you within a couple of weeks for follow-up to review the testing, and then we conclude the visit and come to probable diagnosis, and we take it from there.
Thank you, Dr. Aziz. That was very, very helpful. I think sometimes there's a lot of confusion and sometimes anxiety between, my primary doctor, my specialists, and the different appointments. Amy, can you just briefly talk a little bit about the telemedicine visit, how that's been going in your practice?
Sure. We've actually transitioned mostly to video visits, which has been working out quite well. It's taking a lot of work on the front end to make sure that patients and caregivers can have the technology available, but really anybody with a smartphone, internet access can participate in a video visit. So I think it's been really helpful. We started out with some telephone visits, and those are fine in some instances, but the doctor really needs to see the person and have them do certain things especially during initial assessments when we're meeting them for the first time. So don't be scared of telemedicine, of virtual visits. I know it can seem really overwhelming, but hopefully caregivers can help, and at least I can speak for our staff at OhioHealth. We're walking you through every single step of the process. So it can be a really helpful tool, and especially for people that have a hard time, even without the virus, have a hard time getting out of the house. This can be a really good option rather than not having care at all.
And driving is a problem. I mean, many people actually don't live in the area here, so traffic and driving in itself, it can be compromising, and it can deprive many people from the care that they deserve. So having the video visit give us access to more remote areas, and you can now ask your physician, can I get evaluation at my home? So which is a big advantage. You can get the opinion at your convenience rather than traveling all the way to Columbus to see us in our clinic, and that can need someone to free several hours. It might actually cancel the whole day for one of your siblings or your children or someone who's taking care of the patient.
Great. Thank you so much. That's very, very helpful. Dr. Aziz and Amy, I'm going to switch gears here just a little bit because we had some questions come in from some families where their loved ones are in facilities. And, that's always a little bit of a different animal. It can be very stressful. And now with the pandemic going on, there's that added layer of, confusion and complications for families. So I have a couple questions from families related to that. This caregiver family member wrote quite a bit of content, so I'm going to try to just box of her question. her mom's in a facility and she's been there and she's been doing well. She's elderly at 90. And thank goodness at this point they do not have any of the COVID-19 in the facility. But as we all know, the facilities have really gone on into a lockdown mode, restricting visitors and contact. And this particular daughter is very concerned, even though her mom doesn't have COVID, but she is elderly and she is in a facility and she can't see her. And she's very isolated and she's concerned about the personal protective equipment the staff is wearing and the masks and does she understand what's going on? And what are your thoughts about, are there ways that our families can help those folks who are isolated in the facilities?
I will give Amy a chance to start there. Go ahead,
Okay.
Amy, if you have any thoughts
Okay.
there.
I know that this COVID situation has been hard for patients, hard for caregivers, but also hard for facility staff because they want families to be involved too. So this has been difficult, to balance everyone's safety. I think hopefully the facility has been communicating well with you as a caregiver. Giving you updates on how your mom is doing. Of course, you should be keeping in contact with them. If you ever feel like they're not giving you information or you're not getting the right information, if you feel like you're not getting answers after going through the chain of command there, talking with a social worker if there's one there or a director of nursing, you always have the right to call the nursing home ombudsman for your area. If you have some really serious concerns. Now, before that, I would, of course, talk with the staff there about other ways that you can connect with your mom. And maybe that's through a smartphone. Maybe they have iPads that they can take into your mom's room and set up, and so that you can see her and she can see you. You can have some conversation. Maybe they'll have some scheduled times that you can do that. Because I know every caregiver is struggling with this, not being able to see their loved one. So I have heard some anecdotal things from places that's what they're doing, is that they have iPads available and that's how they're having people communicate with their loved ones. Or if a loved one has a smartphone already, you can communicate that way. So I think it's just kind of thinking outside the box on how to communicate differently. This is really, really, really hard. And as a caregiver, I think it's making sure that you get extra support because there's a lot of, I think, some fear and guilt involved in not being able to see your loved one as often. So connecting with other caregivers that are feeling the same way, trust me, sometimes that can help you cope a little bit better.
And I think it's enriching the environment of the patient can be helpful. So having pictures, sending things that sanitized well, etc., to her environment, making her feel like home. Getting her stuff that she used to love all her life can give her some comfort. So there are some adjustment to her environment can help too. But keep in mind, as Amy mentioned, there are two sides to this story. So your feelings and the reality. So your perception of the reality and the reality itself. So the patient might not be aware of what's going on. If it's really advanced dementia, they usually deal with day-to-day situation. Most of the dementia start with language or start with behavior, but eventually affect memory and executive function and decrease our ability to realize what's going on. So your mom might not be as stressed as you imagine about the situation because she's not understanding it, and that can be a blessing. It's the stress can be in your side, you assuming many things that she might be stressed and she doesn't see us, and that can be stressful for her. And that's sometimes those type of negative thoughts might not be very helpful. So try to stay in this positive side. Try to introduce as much as you can. Try to make her as comfortable as you can. And that's, I think, the best thing we can do beside the adjustments or the interventions Amy mentioned earlier. But I mean, I think most of the time the patients at certain stage, sort of their universe become too small, but at the same time, they are comfortable in that zone. So it's the body is very smart machine, and it's actually try to preserve energy, and one of it is comfort. So most of the time the patient is comfortable if they get the care that they need. And that's, I think, is important to take care of some of the stress that you have. But again, nourishing the environment can be helpful, being there for them can be helpful for both of you, especially you are obviously from your question, you are concerned about, is this could be the end? I'm sorry to say this, and you are concerned you might not be able to see your mom anymore. So try to do alternative ways, think outside the box to take that out of the concern that you have.
Yeah. Dr. Aziz and Amy, thank you so much for those answers and addressing that, really tough issue for our caregivers and our families. I know our program teams, we're hearing a lot of concerns about that. So thank you for addressing that delicate issue, because it is a balance. We have a lot of hardworking folks in our facilities who are working to protect, all the residents and the staff, and it's just that this is just really a very, very tough time. And I love what you said, Amy, about making sure that the caregivers get the support that they need. And certainly, the Alzheimer's Association is here to do that. I have one other question, Dr. Aziz, about being in a facility. And this comes from a family member where their loved one is in the middle stage and they have very aggressive behavior. And the family is concerned that, she's been moved once out of the facility, and they're concerned that maybe she would be moved again. But of course, the COVID restrictions are playing into this. And they feel like her aggressive behavior is escalating. Would you have any thoughts or recommendations so that the family's concerned, so that she doesn't get kicked out of another facility? Any thoughts on that?
Yeah, this is way more delicate than any other question. It's a very tough question, because at one stage of the disease, most of the filters are gone. So the patient is actually acting more natural and expressing their feelings. If they are frustrated, it shows right away. If they are hungry, it will show as agitation. If they didn't sleep well, they will be aggressive. And many times the facility doesn't have the staff, the capability, the training to handle this type of behavior, and our beloved one ended up between the rock and hard place. So it will be difficult for the facility to keep them, because they don't have their appropriate ratio, and they have to take care of other residents, and it can interrupt the flow. So they are forced to make that type of determination. And the family, this behavior can be overwhelming to the family too, because if you bring the beloved one at home, they probably will continue with the behavior because it's part of the disease itself, and it's consuming to the patient and the caregivers, and they might not be able to handle this. So this is where it's become delicate. So many times we try to behavioral adjustments, but many times the behavioral adjustments are not enough. So we ended up using medications. The pharmacological interventions, the goal of the intervention should be clear. What are we trying to achieve here? Because agitation can be manifestation of multiple things, but medical-wise. So the first step, we review the patient medications. Some of the medication can make the agitation behavior worse. So for example, some people use sleep aiding pills like Phenergan or those type of medication. Those medication can make agitation worse. Some of the medication we use for blood pressure or other reasons also can make agitation worse. So the first step is to look what the patient takes, try to trim it, because if we are planning to introduce other medications, we try to balance the act. So we try to minimize and use the most efficient medications. The stage of the disease, if it's moderate or advanced, some of the medication that we commonly prescribe to healthy people become useless because they are preventative treatment, like cholesterol medications. Cholesterol medications like statins, we use them commonly if you have high blood pressure, you have high cholesterol, but if you are in moderate or advanced stage of dementia, sometimes we eliminate those medications. What's the point? Because their preventative power measured by the scale of 5 years. So they are not helpful to prevent heart attack in a year or 6 months. They are helpful to prevent heart attack or stroke in the scale of 5, 10 years and so on. So if we are expecting the disease is advanced and with the life expectancy is not 10 years or 8 years or 7 years, those medications become burden rather than help. So the first step usually I look at, as I said, the reason of the agitation. If I can find reason for agitation like UTI or something, I try to fix it. Look at the medication. If the medication contributing or the interaction between the medication add to this situation, I try to take care of that. And if those type of conservative thoughts didn't help, I try to introduce medication for that. There are family of medications we use to treat agitation. So commonly we use antipsychotic medications. Usually we go for the newer generations like Seroquel, Risperidone, Olanzapine, Clonazepam. Those medications, sometimes we use them. Sometimes we use antidepressants. Sometimes we use some of the seizure medication that proven to have impact on reducing agitation behavior. So it depends on the patient medical profile. We decide which medication work best. Because some of those medications, if you have heart disease, they are not the best medications for you. If you have kidney problems, some of those medications are not good for you. So we try to figure out what's the best choice among those medications that we can introduce to treat the behavior. The discussion after we think about part of this discussion about the choice of medication is the expectations. What are we trying to eat here, to treat here? And what's the expectation? And it will come on an expense there. So sometimes when we are trying to treat agitation, we end up with some form of sedation. So we need to be prepared for that, because when we introduce those medications, the beloved one will become more sleepy, less engaged. So we need to find this sweet spot there that give us the benefit of the medication, make the behavior, the agitation manageable. Sometimes we don't try to eliminate all the agitation if it's part of the disease and it's inherited part of the problem. Sometimes we don't try to eliminate it completely. If it's just outburst of verbal thing that everyone can listen to and ignore, I don't want to treat that if we can live with it. So, but if it's physical and the beloved one pushing the caregivers, it's refusing treatment, refusing to eat, refusing to shower, and it's compromising her well-being and her quality of life, then we keep treating and adjusting the medication until we find the spot or the doses that work best for the patient, that make them more cooperative and they are less agitated. Most of the time, we end up with combination of medications. So sometimes we add 2 medications to control the agitation and the verbal tics or verbal behavior. Sometimes we try to improve the quality of sleep, so we give antidepressant with agitation medication. Sometimes we play around it with a couple of medications to figure out what's going on and treat it appropriately. But in summary, we try to understand the underlying problem. If there is something we can fix, we fix it there. We don't. The behavior is manifestation. The agitation is quite common to be manifestation of something else. So it's not smart to treat the agitation without exploring if it's caused by something else. If it's due to sleep, if it's due to dehydration, if it's due to infection, we need to fix that. If we keep hammering the behavior, we are not treating the underlying problem, we are not helping, we are causing more damage than help. The second thing is the behavior worth treating. So if it's just verbal outburst, etc., and we can adjust to it and find a way to deal with it, it's better to do behavioral, non-pharmacological. Then we review the medications. It's quite common at this stage, medication are we are overprescribing. So it's very important to review the medication. They can contribute to agitation. Then we blame the disease at the last stage. Then we go to that balance between sedation versus agitation, and we try to find the perfect combination that can help us to deal with that. Keep in mind, it's trial and error. So there is no physician can give you one medication and give you guarantee it will work for sure. There is nothing like that because every individual is different. So it's a little bit protracted process and need a lot of communication and good relationship with your care provider. So you find the best answer through that process.
Very good. Thank you. Thank you. We had another question, and we get this quite often as well on the program teams. Can you talk, and you've mentioned it a couple times today, can you talk about UTIs and how they affect a person with dementia?
Yeah, UTIs and infections in general are very prevalent. They are common at this age because of many reasons. So as you grow older, men and women have different urological issues, either related to incontinence or flow problems, and that can facilitate infection. So infection at younger age commonly present with pain, fever, agitation, sleep problems, and fatigue, tiredness. There are a certain set of symptoms. At older age, with the dementia, the manifestation can be atypical, unusual. So it can be agitation, it can be sleep problem, it can be sleepiness, it can be decreased appetite. So usually if there is sudden or rapid deterioration of the beloved one in their cognitive or functional ability, UTI should be in the background. We should think about UTI because it's not necessarily to have fever. Sometimes it's actually go to the other direction. It can cause hypothermia. It can decrease their temperature, and they can be shivering rather than having sweating. So we should have low threshold to think about it. It's easy to test for UTI. So although it can be complicated in real life if there is incontinence, because to catch clean sample, sometimes it's a little bit difficult for this population. But if we test the urine and we find that there is UTI, it's need antibiotics. Keep in mind the treatment itself. The antibiotics are strong medications, and they can cause agitation and they can cause cognitive changes. Most of the antibiotics are strong medication for this population. So during the treatment, they can show other manifestation related to the treatment itself. We need to keep up with that. The treatment might take a little bit longer time because the microbes that affect this population might be different than the common ones that we see when we are younger because of our immunity and other factors. We might have a typical type of bacteria and so on. So they might need special consideration and special antibiotics, and it might take a little bit longer. The recovery process, it might take also longer. So when you have flu or UTI and you are 40 or 50, it might take 3 to 5 days for you to get back to yourself. In our older population, because of what's going on with the whole body, the recovery time, it might take several weeks. So we need to be patient with them. Treating UTI usually include treating hydration situation because it's quite common UTI to be associated with dehydration. So we need to make sure that the kidney function stays intact, and we need to make sure that they get enough fluids while we are treating this, because we don't want the kidney to be damaged because of the UTI and the antibiotics and the pain medications and so on. So hydration and preventative measures, including feeding the patient well, providing supplement, are very important. So UTI can present in an unusual way in this population. It can last longer. It might need special type of antibiotics, and we keep it in mind every time we see rapid deterioration in the performance, cognitive performance, even if we don't see fever or complaining about burning sensation in urine and so on, which is classical presentations of UTI.
For sure. Great. Thank you. We get a lot of questions about that and run into that quite a bit. Well, we are about 3 minutes to the top of the hour. This has been just an excellent discussion. Dr. Aziz, Amy, do you have any closing comments before we sign off?
So one of the questions was about research. So I will have 1 minute about research.
Sure.
So
Great.
the development, I mean, in the research, we are in like people who, oncologists, cancer specialists, 40 or 30 years ago. They were trying to fight many cancers, and our knowledge was very limited about the reason of the cancer, how we treat it, etc. And as the time went, now we are able to cure many cancers. Breast cancer, people cured from breast cancer. Colon cancer, we are screening for them. We are able to do many things to treat and cure cancers. The dementia situation is in the infancy regarding our knowledge, and we are building knowledge. We don't have treatment, but we need to be patient. We need to be supportive to the research because it's very important we continue the effort that's going on. The exciting news is about diagnosis more than treatment. So there are many advances in diagnosing many dementias, and we have PET scans, we have spinal taps, and nowadays there are many tests that goes to serum testing. So they are the scientists trying to come up with some blood tests that can tell us if you have Alzheimer or not, or Lewy body or not, and those will change the landscape of the research and finding cure for those conditions. So there is a lot of excitement there, but the treatment-wise, we are not as advanced as we hope, but eventually we'll be there if we continue the hard work regarding research. Amy?
Oh, no, I think you summed that up well, and I just appreciate you having us on here. And I know we haven't necessarily been able to get to everyone's question, but anyone is happy to reach out to us, or we're more than happy to help.
Absolutely.
Pleasure to be here, and thank you for giving us the opportunity to share our thoughts and engage in this conversation.
Well, Dr. Aziz and Amy, thank you so much. We really appreciate you coming on and talking with us and sharing with our caregivers and our constituents. So thank you, thank you, thank you.